Hi, Nathan Ritter from cardiogauge.com. I'm a cardiologist in New York. Let's talk about lipoprotein(a) and what to do if your level is high. Let's get right into it. When you get your measurement, step one, you want to know, is it in milligrams per deciliter or nanomoles per liter? And this is a mistake I see a lot of patients make. So they get mixed up with the units, and that can get confusing. So the measurement values, there's two types, the milligrams per deciliter system and the nanomoles per liter. This system is preferred, and more labs do it like this now. But there are plenty that do it like this, and I have numerous patients who had the milligram per deciliter measurement. You can multiply the milligram per deciliter by 2.5, and then you'll get the nanomoles per liter. There's some subtleties with all that, but anyway, more or less 2.5. And as I mentioned in my video about the lipoprotein(a) basics, if you haven't seen it, you should watch that first. There are 4 categories: normal, medium, high, and very high risk. But first you want to know what your units are. Well, and then you want to categorize yourself, which of these 4 categories are you in. So if you're in the medium risk category, no one would really know for sure what to tell you with that one. It doesn't change your risk overall that much, 20% higher than it would be without it if it had been normal. The higher risk, 50% increase in risk, that starts to be noticeable and worth paying attention to. And then clearly the very high numbers, so greater than 180 or greater than 430 nanomoles per liter. Those increase a person's risk 2 to 3 times above what it would be otherwise, again, equivalent to being a heavy smoker. So if you're in the high or very high category, these guys here, I think it's worth it to think about what your choices are for treatment. By far the most obvious thing to do is take an aspirin. I can't tell you to take an aspirin, but that would be a general recommendation I would give most of my patients. Why is that? So lipoprotein(a), it promotes clotting, and aspirin obviously prevents it. So there's some logic to why it might work. Aspirin might decrease heart events in people with elevated lipoprotein(a). Aspirin was tested back in 2019, and it did not work well in primary prevention. It was kind of a big deal. It was an aha moment for the medical community, who had recommended primary prevention with aspirin for decades, but it turned out it didn't really work that good. If you just used it in all comers or people with hypertension or diabetes, those types of risk factors, it did not produce enough of a risk reduction to offset the issues with bleeding that come along with aspirin. But some smart people ran the numbers on the patients who had high lipoprotein(a) or genetic predisposition to that. So they weren't big randomized trials specifically addressing the question, does aspirin work in primary prevention for elevated lipoprotein(a) patients? But they did a nice job in trying to approximate that. And there were a couple of studies, several. I'll put some links in the description. But bottom line is that aspirin reduced risk by a lot. So if a person is in the high risk category or the very high risk category, person's age is more than 40, there are no bleeding issues, and especially if that person has strong family history or high CRP, then aspirin makes sense to me. And that's not a guideline or a mainstream recommendation, but it makes sense, especially with this or this in addition. The current information we've got from these studies, Women's Health Study, MESA study, it implies a decrease in risk of heart attack by 50%. So that would cut your risk in half. And recall that over here, if you've got very high level, you're at about 2 to 3 times the risk. Well, if you cut that in half, you're back to where you started. So by using aspirin, you could theoretically get your risk level back to where it would be without an elevated lipoprotein(a). And importantly, relative risk is kind of not a super useful concept because it doesn't tell you what your chance of benefiting from the medicine is. So that's when you talk about absolute risk. And so 50% relative reduction would translate into an absolute reduction of somewhere around 5 to 20% over 10 years. And this is quite large. So in people who are at high risk, maybe they have high diabetes, high blood pressure, and they are 65, 70 years old, the person will have a substantial risk, and you can cut that in half and get somewhere in this vicinity of a reduction. What other choices are there besides aspirin? Well, there's the old standby. Don't gag, everybody. LDL lowering. Because we cannot effectively lower lipoprotein(a), we're kind of stuck using the usual means, yawn, to decrease risk. So it turns out that statins work. People with elevated lipoprotein(a) who take a statin do have lower risk than someone who does not take a statin with the same numbers. Unfortunately, statins increase lipoprotein(a) by about 20%. What that means in terms of heart attacks and strokes, nobody knows. But the data implied that statins do not increase the chance of stroke or heart attack in people with high lipoprotein(a). It's important to note that statins decrease LDL-associated risk. So it's a lot like if a person's a smoker and they have high blood pressure. Well, you quit smoking, you decrease your risk, but you remain with the risk related to high blood pressure unless that's treated. Same kind of thing with the lipoprotein(a) and the LDL. Statins are especially critical if you've got a strong family history. You cannot run, you cannot hide from a strong family history. Statins remain the most standard tool for primary prevention in somebody with a family history. Other choices for treatment include ezetimibe, that treats the LDL. It does not increase the lipoprotein(a), and it's a good option when you combine it with a lower moderate dose statin. So, for example, rosuvastatin 10 milligrams per day, ezetimibe 10 milligrams per day. That's a nice combination. There's a lot of LDL lowering with that and a lot of reduction in risk. Then there are the injectable cholesterol medicines. So Repatha and Praluent, these are the generic names. They lower LDL, but they also lower lipoprotein(a). So theoretically, they're attractive in people with high lipoprotein(a). And if a person were a real stickler and they wanted to bank on the hypothesis that a lower lipoprotein(a) lowered their events, then they would insist on Repatha or Praluent to treat their LDL. And that might make sense in somebody who has heart disease and has a high lipoprotein(a), I suppose, but that's an unproven hypothesis. The minuses of these things, these medicines, they're expensive. It's hard to get them from the insurance company. They're an injection twice a month. Other choices here. Well, obviously, you manage your other risk factors, and that's represented in this diagram here, where I'll be going through these in other videos. And as with anything in this whole business of preventing disease of any sort, there's the rabbit hole. The rabbit saying, "Come follow me down the rabbit hole." If you Google it, it'll say, "Oh yeah, niacin, that lowers lipoprotein(a). But actually, in a large trial, it did not reduce risk of stroke and heart attack. And this is the AIM-HIGH trial, where people were given niacin, and they split up the patients after the fact, split them off with elevated lipoprotein(a), and those specific patients did not benefit from niacin either. L-carnitine, in terms of supplements, is kind of probably the most promising one. And that lowers lipoprotein(a) by 10%, and it has some other potential benefits. But the kicker with L-carnitine is it increases TMAO, and that's associated with increased chance of heart attack and stroke. It's a bummer, because I wish there was a supplement that I could recommend to you guys to go out and get, but can't do it because of this facet of L-carnitine's effects. And then there are a host of other ones which come up, but they just barely affect the lipoprotein(a) at all. CoQ10, garlic, resveratrol, flaxseed, no or minimal effect. So those are my thoughts about treatment if your lipoprotein(a) is high. What's in your hands, if you don't have a doctor, is you can do a home test, and you can decide for yourself if you want to take aspirin. And that's kind of, that feels good. You're in control of that. The medical establishment cannot prevent you from testing your own lipoprotein(a). and it cannot prevent you from taking an aspirin on a daily basis. So if you found yourself in a high risk category, you might consider that. I can't tell you to do that, obviously. I should mention that anybody who finds themselves in the super high risk category, very high risk, over here, it makes sense to talk to a cardiologist, I think, or somebody who knows a lot about cholesterol problems, because you could get further testing to understand your risk, like a calcium score or a carotid Doppler study. Certainly, everybody should have a CRP test too. It'd be a separate video, but those things would be for sure if you are here. All right. Those are my thoughts about what to do if your lipoprotein is high. See you in the next video.